Good evening, Ganesh bhai.
Good evening, sir. Good evening.
Uh, there are many questions that the students will have in their mind. So I
हाँ
think,
सर,
you
अभी
know,
ज्यादा होना नहीं चाहिए. Many of these exam going students have gone to Nadiad also.
but then it depends upon who is taking their onco. The person like you, if they take, then it's a different story, na. But
Yeah,
the people
बराबर है.
who are
कभी
doing
कभी
all
क्या
the
होता है ना.
surgeries,
नहीं नहीं, agreed. I told you ना, वो मतलब you are in USI council.
yeah,
वो थोड़ा सा.
yeah, we'll have to update. We have to tell that all those who are examiners, they should, update themselves with the branches which they are not doing regularly.
Okay.
So who is answering today?
चालू कर सकते हैं अपन, ऐसा कुछ नहीं, बाकी विल ज्वाइन.
हाँ नहीं they will join. Just अभी 2 मिनट है,
Good evening, sir.
2 मिनट में करते हैं.
Sir,
Good evening, sir.
Doctor,
I'll be answering, sir.
ये
Dr. Aditya Govind.
स्क्रीन किसका है ये?
ये- This is नहीं, this is Bridges' skin.
Okay.
Listen, we have, last time we had discussed about the stones, and
हाँ.
that time we were discussed. This is a stagon calculus we had discussed. So, we had asked them question from where you will enter, and there is one uh, this thing procedure. I wanted to show them that how
बराबर.
to use the black uh, covering over the piston while
Okay.
doing PCNL, how to use it so that when you are injecting after doing PCNL and implants being in the kidney, when you inject dye, okay, the dye will not come out and it will remain in the system to see. So as you just enlarge this, there are three nephrostomy tubes. All three are of different size. So if it is a very small 16 French, we can take 2 cc syringe. That is this thing lever lock syringe, and the piston has got that black color covering, so that you can put it, and through that you can bring the guide wire. For 20, we use 5 cc syringe, and bigger one we use 10 cc syringe piston. And as you can see, it's sterile. We can use it and use the 18 number needle to bring out this guide wire. And then from ureteric catheter, if you inject dye, as you can see here in the screen, you can see it very clearly. The dye has gone into each and every calyx. And you can, if you are missing any stone, you can see it and you can puncture it. So this is the jugaad I wanted to just uh, show all the students because we had discussed it last time.
Okay. Yeah.
So that is why I told him that in the beginning, just keep these photographs so that everyone can see it. And that also we were discussing from where to enter, which calyx, because it is a stagon involving each and every calyx. So here we enter through, uh, show the first film. Yeah. So we entered through the lowermost calyx, and through that we were able to remove almost 70% of the stone burden. Dr. Gite is traveling today. He is going back to from Nasik to Aurangabad.
Okay, sir.
So he was discussing with me, and he was telling me that sometime it is difficult for him to, join. So if it is really difficult, then what we will do is that instead of Thursday again, if ISU has got no meeting on Tuesday, then like earlier, we'll change our timing from Thursday to Tuesday.
Okay. Pankaj sir has joined, I think.
Yes, I
हाँ
have.
पंकज, yes yes,
सर
पंकज भाई,
ट्यूसडे मुझे थोड़ी दिक्कत है.
हाँ okay.
ट्यूसडे एज आई हैड टोल्ड यू एक लेट इवनिंग ईएयू का सेशन होता है विच स्टार्ट्स एट अराउंड 10:30
Oh, okay.
which I like to attend.
Okay, no problem. Though
So any
because
day other than Tuesday is good for me.
okay, so we'll discuss out. I'll ask
Yes,
Dr. Gite also. He
yes.
has told me that he, you know, if it
So
is very
वेडनेसडे रख
difficult,
लीजिए सर, हमें वेडनेसडे में कोई परेशानी नहीं है, यानी डॉक्टर गीते शुड बी देयर, एनी डे इज गुड. But if
yeah,
it is Thursday, then I'll need to come out of the meeting at around 10:30.
okay,
हाँ,
understood.
हाँ.
No problem. No, we'll keep it on such a day that when all of us are able to join,
Yes,
because
yes.
I don't want any one of you. You are the most important
नहीं नहीं
faculties.
सर, ऐसी
As a
बात नहीं
student,
है.
नहीं, in your subject, students are learning so much. So this thing. महेश्वरी जी, आपने देखा ना? You saw that photograph?
I saw, sir. I saw, it's a fabulous thing, sir. I saw
That
the
yeah,
syringe का adapter that you put.
correct.
सर एक एसआईयू में एक सेशन होता है विच इज कॉल्ड एज बंटू.
Okay.
उसमें ये जो जुगाड़ है वो प्रेजेंट हो सकती है.
Yeah. I actually, you remember I had done the whole 10 minutes ka with Vinit in this in Madhya Pradesh, apna,
ओके.
uh, on the all these things only.
नहीं नहीं सर, ये वाला हम बात करेंगे, इसको एसआईयू में भेजते हैं सर.
Okay,
हाँ.
definitely. Yeah. Acha, okay. Who are answering?
सर मैं 1 मिनट चार्जर लेके आता हूँ.
हाँ. But who is answering?
Sir.
Rahul, you are answering?
Yes, sir. I am answering.
Aditya?
Yes, sir. I'm also answering.
Anubhav?
Good evening, sir.
Who else is answering?
Dr.
Sir,
Aditya for this
Sir, I'm,
case.
sir, I'm Dr. Rathod. I'm also
Dr. Rathod and
Okay.
Dr. Aditya, sir.
answering.
So Dr. Rathod, Dr. Aditya Goel, and Rahul.
Yeah, sir. This is Dr. Aditya and Dr. Rathod.
And Rahul. Rahul is not answering.
yes, sir.
They are answering for the second case, sir. Dr. Hamid, Dr. Rahul for the second case.
Okay. So at present, Aditya and Rathod is answering.
Yes, sir. Yes.
Pardon?
Yes, sir.
Aditya and Rathod, correct?
Yes,
Yes,
sir.
sir.
Okay.
Yes, sir.
Sir, good evening, Mahendra.
गुड इवनिंग महेंद्र.
अच्छा, महेंद्र ज्वाइन किया?
Sir, good evening.
हेलो. हाँ बोल. कर दिया ना? ओके, थैंक यू वेरी मच. Can we start now?
Yes, sir. तो सर
Can we start now?
तो स्टार्ट करते हैं. तो व्हाट वी डिसाइड कि पहले केस में हिस्ट्री वगैरह सब करने का, बाद में कुछ नहीं, राइट?
Yeah.
Maybe we can also keep some time bound discussion because all are exam going now.
Yeah. So that is why normally we are doing, each case we are finishing in between 30 to 40 minutes.
Okay.
Okay. So Brijesh, you only present, or let them. Who is going to present this time?
Yeah, Dr. Aditya and Dr. Rathod are there. I will be there, sir, with the help. I can also.
Okay. So who is going to start? Aditya?
I can start,
Yes,
sir.
sir. I'll start.
Okay, start.
Sir, she is a 62-year-old female presented with chief complaint of mild pain over left flank since 1 month, hematuria since 10 days, sir. So, patient was asymptomatic before 1 month. Later, she started complaining of very mild pain over left flank region. Pain was dull aching in nature, non-colicky, insidious in onset, non-radiating, gradually progressive, not associated with nausea, vomiting, or fever, no specific aggravating factor, relieved on taking analgesics. Patient was also noticed passage of blood in the urine since 10 days. It was sudden in onset, painless, non-progressive, and self-limiting. Hematuria was completely associated with the passage of few warm like clots. Symptoms were insidious in onset, gradually progressing with no specific aggravating or relieving factors. No history of dysuria, no history of lithuria, no history of colicky pain at time of hematuria, no history of previous instrumentation or catheterization, no history of nausea, vomiting, no history of jaundice, facial puffiness, exertional breathlessness, lower limb edema, no history of backache, bony pain, weight loss, no history of bleeding disorder, anticoagulant therapy or blood transfusion, no history of radiation or chemotherapy. Past history suggests no diabetic, non-diabetic, non-case of hypertension, medication, telmisartan, 40 milligram OD over 7 years. Family history, non-contributory. Personal history, diet, mixed diet with normal appetite, bowel and bladder normal, sleep is normal, non-alcoholic, non-smoker, non-tobacco chewer. On general examination, patient was examined in well-lit room with proper consent in supine position. Patient is conscious, cooperative, well-oriented to time, place, and person. Pulse was 80 beat per minute. ECOG score 1. BP 132/80. Respiratory rate 18 per minute. Febrile, SpO2 98% on room air. On general examination, no pallor, icterus, cyanosis, clapping, lymphadenopathy, edema. Spine examination was normal. Per abdomen's examination inspections, flat abdomen, centrally placed and inverted umbilical. So normal abdomen, thoracic respiration, skin, no scar, sinus, dilated vein, no visible swelling was there, no renal fullness, no visible peristalsis or pulsation. Hernia sites clear, external genitalia normal. On palpation, normal temperature, no tenderness, no obvious palpable lump present, no renal angle tenderness, hernial orifice, no cuff on impulse, external genitalia NAD, spines suggest no deformity or tenderness. Percussion, abdomen, all around the tympanic sound was there, renal angle dullness, auscultation, no bruit, bowel sound normal.
Okay, fine. So now, Dr. Rathod,
Sir, please.
yeah, what is your impression? What is your clinical diagnosis after? Or what are the differential diagnoses you can think of?
Sir, can I make some comment?
Hello.
Am I audible? Sir, Mahendra here.
Yes, Mahendra, go ahead.
Yeah. So in the history, I think history of trauma or history of passing a stone. Two things were missing. I think rest things were okay.
वो लिथ्यूरिया मेंशन किया था.
अच्छा, तो trauma was हाँ, trauma was I missed, I guess.
Yes, yes.
And the second, if suppose that this patient would be a male, so how it would be different examination compared to female in the patient having hematuria? What extra thing you would like to see in the male patients?
Sir, I would like to do DRE examination also in the male patient in cases of hematuria.
Okay, anything else?
And
You would like to know associated LUTS symptoms with
Sir.
male patient.
Okay, maybe young patient or maybe any male patient, what you will look on examination specifically, not you will not see in the female.
any it will be external genital examination, sir, and any phimosis or any other other.
It is very obvious the patient having hematuria, passing clot in urine, either he will be having some benign or malignant pathology.
Sir.
So what specific thing would you like to examine in the male patient in the genitalia? Varicocele.
Yeah, sir, varicocele. Yeah.
Okay, because I don't know if next few patients are male or female, so I just raise this important thing to just complete the examination. Okay, and again,
Yes, sir.
lower limb edema, that may be because of DVT or maybe lymphatic blockage. You also should examine in general examination.
Right.
Okay, so now go ahead. What Gaurang Shah sir was asking, you have history, you have examination, you have done. So what your differential diagnosis?
So, Mahendra, before you proceed, Aditya, what is the significance of varicocele?
So one of the differentials here would be RCC, sir, in this patient. So if it's an RCC involving the renal vein or the IVC involvement is there, depending on the site, we could say varicocele could be because of that, so a non-reducible varicocele.
Sir, in cases of RCC with renal vein thrombosis in left side, patient may have irreducible varicocele, sir.
Yeah.
And
So it is more often seen on left side.
left side.
Again, IVC thrombus are very rare to go downwards. They usually go towards the heart. So right gonadal vein getting blocked is very unusual. So varicocele you will invariably find on the left side, and it suggests a left RCC going into left renal vein. Chaliye,
Yeah,
आगे
but
बढ़ो.
both of you, matlab, at this stage, if you say it is RCC related, only examiner say you know the case. So when Pankaj sir जैसे आदमी पूछता है कि what is the importance of varicocele, you say it general and RCC. Okay, that would be better.
Absolutely.
So इधर अपने को पता है ठीक है, but exam में you are not going to know that this is a RCC case. Only positive history of a say 62-year-old male with hematuria, which is slowly progressing. It can be so many things.
So I think, sir, the
So
better
anyways,
way to
come
answer
to the DD now.
will be the any
Zyada.
pathology which can cause thrombosis on the left renal vein for the left side varicocele, or maybe IVC obstruction affecting the gonadal vein on the right side.
Barabar, but as such, varicocele can be idiopathic also.
Yeah, yeah.
So that is how probably we should begin with, in a general way.
Yeah.
Okay. DD, clinical differential diagnosis. So can you just say what is the positive points in your history? 62-year-old female with
Dull-licking flank pain and hematuria associated with hematuria. Whenever there was hematuria, there was no associated pain at that time. And
so
apart
you
from
say
that,
painless hematuria, which is
painless.
occasional or periodic or episodic or whatever you want to say, but say these words very choosy. Matlab, say these choosy words. We are asking you to summarize, so don't go again with the history. We are not going to waste much time today in history in the further cases which you have today.
So it is an elderly female patient with flank pain and hematuria. Most likely the differential diagnosis would be stone disease involving the upper tract malignancy, or could be RCC, could be any renal cystic disease, and last I would like to keep a bladder malignancy as in differential.
Okay, not lastly upper tract urothelial.
Since the clots shapes, I want to keep it a bit higher, sir, as compared to bladder malignancy. So I kept it as second differential.
Okay. Hello.
See, whenever there is a painless, that is what we are taught, whenever there is a painless hematuria, okay, and then in the differential diagnosis, if you keep malignancy higher, there is no, problem. Because we are taught like that whenever there is a painless hematuria, not associated with anything else, then the chances of malignancy are very high. So in exam also, if you keep it little higher, you don't have to worry. If there is nothing like this, hematuria, only pain is there, then I think it will come at the end. Yeah. Okay, so now next, what you want to do?
Sir, I want to do the basic blood investigations in form of complete blood count and renal function test with the and serum electrolyte with urine REME and urine culture, sir. And with the as a ultrasound KV, the extension of clinical examination. And patient is diabetes, so I want to show his current blood sugar control in. So I want to do the hemoglobin A1C also.
Fine. So my question, Aditya, my question is, you want to do sonography or you want to do CT, CACT, abdomen and pelvis? See, in exam, yeah, see why I'm asking you. You justify that whether you want want to do sonography or CT scan, and Rathod will try to justify other way.
So since sonography will give me the initial idea, sir, and I don't want to expose the patient to radiation initially. I would like to get a sonography done. That will give me a basic idea about the pathology, which will help you to choose which type of, say, if required, CT scan needs to be done or not. And if a CT scan is needed, whether I would want a contrast, non-contrast, a triple phase could be decided based on what I find on the ultrasonography. I would like to get ultrasonography done first, and then proceed with more invasive or more.
Okay, so you can say that ultrasonography is an extended clinical investigation for me, and depending upon that, so how it is going to make how can you make a decision whether you want to do contrast enhanced or plain CT? How it is hematuria? Why you want to do it?
So if I find a renal mass on an ultrasonography, I would be wanting to get a triple phase CT, contrast enhanced CT scan, sir, preferably.
Okay.
But if I find a bladder pathology, I don't want a triple phase in that case.
Why
Correct.
you don't
So
want multiple phases in bladder mass? I would say do a triphasic with a delayed phase also.
See, Aditya, it is only the question of stone. If you find a stone, then you may not do contrast enhanced. You understand?
Yes.
So you should know your answer. If it is only a stone, it is hematuria and it is because of stone, then you don't have to, so that exposure will be less, money will be less, and the complications related to the contrast will be there, absent.
Yes.
Okay?
Yes.
Okay. Contradiction, Dr. Rathod?
Sir, please.
You are saying that, I'm saying that, why to do sonography? I don't want to do sonography. Patient has got hematuria, clots are there. I will directly go for CT scan. Suppose you say in exam CT scan, how you are going to justify? I'm just asking you, whatever justification you can give.
Sir, My justification will be patient is 62 year old, present with painless hematuria and flank pain, and her creatine level is normal. So my first provisional diagnosis will be the malignancy. So if I do the CCT, if I do the ultrasound, if I find the mass, I have to do the CCT to categorize the lesion or from the origin of the tumor or so. I want to do the CECT at first hand only, so I can avoid the ultrasound if it's possible.
Okay, fine. Ganesh bhai, now in exam they should always talk about a sonography followed by CT scan.
Sorry, sir.
Hello.
It is the same way as you justified, matlab, because if it is hematuria, creatinine is okay, you can go ahead with a CT scan.
Okay.
And
So
whoever wants to justify sonography, we have always been saying it is a very easily available bedside test, extension of palpation or whatever examination, and it will lead me to the quick diagnosis, probably to the organ of origin and what I should do next. Both ways.
fine.
I think they will have to
this
be
is
smart in talking and judge
right.
finally what an examiner like you wants.
One thing
Correct.
that you
One
can
more.
definitely say is, as per the guidelines, in a patient with visible hematuria, a contrast CT is absolutely essential, even if you find stones there. So sonography is a part of extension of clinical examination. It gives you the organ of focus, which side you are looking for, and then any patient, and especially in this patient where there are, say, vermiform clots in an old patient with flank pain and hematuria, even if you would have found a stone, contrast CT will still be important to do.
Yes, sir.
So one more statement to support why to go to the CT scan directly, along with the characterizing the lesion and to stage the disease if it is malignancy.
Absolutely.
One investigation can also complete the staging also of the disease if it is malignancy.
But if it is a
Okay.
renal mass, then we'll have need a separate CT thorax. So one investigation will be different kind of.
But CT chest
So
is always there sometimes.
I still feel
Ganesh,
that
Ganesh,
what people should
can
do
we
is
say that we will do a sonography, it shows a renal mass, then I would ask for a say a three-phase CT of abdomen and CT chest. But if
you
I
can,
don't find
no problem.
if I don't find a mass, then probably just a CT of abdomen is more than enough.
You can.
Hmm.
See, it's like whatever you see, matlab, if I see a renal mass, for example, sonography is not sure. If I do abdominal CT, CCT, if I see fat content, it is AML. If I see something different, it will be different. So some things will matter. I would rather say for DNB or MCH type of exam, probably blood tests. If examiner asks you what next, you can consider saying sonography and then jumping onto the CT.
Absolutely.
So please understand in exam how to answer, but at the same time, by chance, if you omit ultrasonography, you should know how to justify that directly why you want to do CT scan. Okay, just show.
So one question, sir. Should at this point we be saying a cytology as well, or we should say that after a sonography?
Unless
Cytology
you are considering
is
a
a part of
urothelial
investigation in
malignancy,
hematuria.
cytology probably would not be needed unless you are considering urothelial malignancy. If you find a solid renal mass, then there is hardly any place for cytology. What do you think, Mahendra?
So cytology, sometimes it can differentiate about TCC and UCC when the CT scan findings are equivocal. So if the CT scan equivocal and cytology is positive, it directly indicates it's upper tract UCC, not the RCC. And in case of hematuria, anyway, cytology is indicated.
Okay.
Okay. So, Mahendra, bhai, in normally, you will say that whenever there is hematuria, along with normal investigation, they should also talk about the when there is no hematuria, that time they will collect for the cytology, correct?
Yeah, yes, because I think it's written in Campbell also. Okay, serum कैसे hematology and urine culture as the investigations to be done with the hematuria. I think it's a Campbell little line is there which I remember.
Okay, fine.
Yeah.
Okay, so Aditya, remember this point. Okay,
Yes, yes.
ask for yeah, show the report. Can one of you read it?
Sir, after examining the provided ultrasound film, it shows right kidney is having normal parenchyma, no hydronephrosis, no any ecogenic structure, or in left kidney there is hypoechoic lesion at upper pole with mild hydronephrosis, and
I think कुछ तो size लिखा हुआ है उधर.
yes sir, 2 by
I mean, it may not be visible, but in case you can see it in your exam, please mention that.
then left kidney upper pole size 2.67 into 2.53 centimeter mass. It's a solid is a solid structures.
Why did you say hydronephrosis? Could you see hydronephrosis there? I couldn't.
Sir, I think there's in left kidney there is pelvis. Looks pelvis.
No, the mass is peripheral.
Yes, sir.
So towards the central side, there is no say anechoic area. So I don't think there is any hydronephrosis there. Anyway, fair.
Sir.
So again, I want to highlight the reading the sonography. Can you go to the sonography findings, sonography films? So how did you decide this is the upper pole mass?
True.
This appears to be the mid-polar, the mid-pole mass. If you see the right kidney and the left kidney, and I can see the border margin of left kidney very well. And for me, it appears to be a mid-polar region, not the upper and lower pole. So please,
Yes.
once you sit with the radiologist,
Sir.
and read at least how to interpret sonography or urological organs, especially kidney. What is sinus fat? What is cortex? Where is the pyramid? What is called CMD at least? Okay, it appears to be mid-pole. Can you see the report?
So few things that you can say here is, one, it is a mid-pole mass. I don't think there is any hydronephrosis, and it is nearly endophytic, just very marginal say variation in the contour of the kidney.
And the third picture showing that from the above.
Yes.
Okay. Report दिखाओ.
Go to the next slide. Yes.
Mid-pole of the left penis. There is solid left renal mass. No other significant abnormalities noted.
Okay. What do you do next?
Sir, I want to do CCD abdomen. Actually triple phase CCD abdomen to better characterization for the mass, and to know the surrounding involvement of surrounding organ. Or
along with the CT chest.
So in EUA
sir.
guidelines, there are 7 things written specifically to see in CT scan in renal mass. Okay. And in oncological cases, you have to focus on TNM, right? In CT scan, as whether CT scan or PET scan, always try to focus here on the TNM. What components are in T, what components are in N, and what components are M, and it all described in the guidelines. Okay.
Yes, sir.
So now can you again say what things you would like to see in CT scan in case of left renal midpolar mass?
Sir, I want to see in CT the size of mass and its involvement. Is it involving the PCS or not? The extension of the mass, and is involving the parenasal sinus or not? I want to see the renal vein thrombosis there or not. I want to see if mass is endophytic or largely exophytic. It's already looking in the looks endophytic only in the ultrasound, but CT have better characterization, or how the rest kidneys functioning. And I want to know the lymph node status, or if there is any sign of metastasis is there or not.
Along with that, sir,
I
whether the
think
mass is
let's put the picture of the CT scan and then he can talk.
So on a sheet of renal vein thrombus, use word tumor thrombus.
Okay, sir.
Label of tumor thrombus.
Roger, sir.
Slide changers हो गए हैं.
Brijesh,
CT scan slide, please. CT scan.
No problem. So, Dr. Rathod, apart from what you said, we need to give some treatment to this patient. So, we need to see the vasculature very properly.
Yes, sir.
Okay. Single, double, branching, venous contour. And then finally, if I were you, I would have said, I would mention the renal score.
Yes,
Okay.
sir.
तो बहुत छोटा दिख रहा है यार ये.
सर आप जूम कर सकते हो.
अच्छा.
हाँ,
वो
फोन पे
कंप्यूटर
करिए,
पे
जूम
नहीं हो
हो
रहा है.
जाएगा.
कंप्यूटर
मोबाइल पे
पे
हो
नहीं
जाता है.
होता.
मोबाइल पे हो जाता है.
हम्म.
So again, in CT scan, you should see adrenal and contralateral kidney. These two things more which you missed.
चलो बोलो.
this is a contralateral CT scan, in which we can non-urological organs appear to be normal and the right kidney appears to be normal. On the left side, we can see approximately 3 by 3 centimeter mass located at the midpole of the left kidney, which is majorly and more than 50% is endophytic. It is near to the hilum. However, involvement of fat sinus or renal sinus cannot be commented here. Apart from that, it is crossing the central polar line as well. So a renal score of for this mass would be around 8. And there are 2 arteries as well.
Anything important thing on the CT scan? So why this score system
2
was
arteries
made?
on the
Yeah. So this
so
scoring
based
system,
on
and this
this
is not.
scoring.
So it is for the complexity and complication.
Okay.
Anatomical physical complexity by the anatomical consideration. Okay. And the probable complications rate after this. So can you see the important thing you missed that to explain actually the renal vein branch of main renal vein is abutting the renal mass. If you see the third image. these are also important thing when you're describing. If you say it's giving only extra marks, so and the picture which you are saying that it is mid polar line. If you see the image 3, it is not crossing mid polar line. The cross section thing image is different. That's why you said that. So the third image, it is totally between the mid polar line.
Yes.
So that also makes it score 3. Yeah.
Yes.
Okay. You say it is 8 or maybe 9 P, A or H or X.
Based on the given films, it is difficult to comment. It is
Okay.
not.
So
I would like
we
to see
can
the
label
Excel
it
films.
as a H. Then you can say X, huh?
X, yes.
Yeah. Okay. So tell us AP and H. What is AP and H?
So A is when it is anteriorly, the tumor is more anteriorly located. P is when it is more posteriorly located, and H is when it is involving one of the branches of vascular branch.
So H is technically Hyler,
Hyler, yeah, not involving.
and X is A plus P. And as you rightly said, it will be seen on the axial imaging. So there is an axial, this is coronal, and there is some more which is sagittal. Okay. So renal score is important. Only thing is, Dr. Mahendra asked you, what is the overall use and importance of renal score?
Renal score tell us about the complexity of
So
partial.
number 1 is complexity. Number 2,
it's post-operative chances of post-operative complications and
predicting post-operative complications. 3 is counseling the patient. 4,
chances of any R0 resection.
that comes in the complexity or whatever complication.
Can be.
Number 4 is standardizing the data.
Okay, sir.
If everybody writes renal score, then the data can be compared well.
Sir.
5th is a corollary of that, which is it can be used in publications.
Okay.
So I think is the CT में बाकी liver वगैरह बोलना पड़ता है actually, which you have missed totally. Dr. Mahendra did remind you about adrenal वगैरह वगैरह.
Sir.
Other kidney, liver, जो सब दिखता है बोलना पड़ता है.
So
if you see by chance lower cuts of the lung or the full lung, you have to mention that also. So don't forget these points.
Yes.
Again, like the sonography, if the size is mentioned, please try to read that size. If not mentioned and if there is a scale, please try to make an effort to say the size with the scale.
Yes.
Okay. I guess so. What will you do next?
I would like to counsel the patient and the relative regarding the need of surgery. And I would like to explain the patient for robotic partial nephrectomy. With the considering the renal score, I would explain the patient all the possible complications that we may have to proceed with the radical nephrectomy if needed, but still, and the attempt would be for a partial nephrectomy.
What complication?
If I am the patient and I ask you, why is treatment necessary then?
For any renal mass, the standard of care. For any renal masses, the chances of it being a malignant mass is around 60%. So it is
60.
always, yes, 6.
Okay.
So so the standard of care for these is surgical intervention in the
so
form
you mean
of
40% chance of benign, eh? That is what I heard. Am I right?
Yes.
40% chance of benign. This is probably a heterogeneously enhancing 3.2 centimeter left renal mass, interpolar.
Yeah.
Okay.
With this enhancement, the chances of malignancy is around 85 to 90%. Very unlikely it's a benign. So
The usual paper quoted in 2005 says 25% chance of benign. There is a Indian data, I think, from South India published, which says which is a later publication, 2013 or 14, which says the chance of having cancer, I mean benign, comes to 10 or 10.5%. And there is a difference in these 10 years in two publications because the CT scan itself has evolved and we have a better interpretation today. So remember, when you say these loose figures, they are not welcome in exam.
Yes.
Two or
Okay.
three things I want to say. Number one is don't directly say, I will like to do robotic partial nephrectomy. Robotic, don't say robotic.
Because see, robotic partial nephrectomy, your boss does. The exam belongs to you.
Correct. So first, I think your answer should be that I will like to do the conservative, the nephron sparing surgery in the form of partial nephrectomy. And then how you will do it, that's a different thing. And second thing is this, that any mass in the kidney, you should think of malignancy unless and until proved otherwise.
Matlab any heterogeneously enhancing mass.
And any
probably.
heterogeneous, yes. And then you should know if you are talking about figures like Dr. Ganesh Bakshi, you should know the proper answer.
So
Okay,
if I ask you a
fine.
question, what is the natural history of small renal masses? Anybody? Quick answer. I mean, you are in exam. ऐसे मत बोलो. Don't take time unnecessarily. We have to go on to other scenarios. I'm sure you have finished your theory exam, so you have read it already. So why are you doing?
So for a small renal mass, the rate of growth is less than 0.2 mm per year, and the
Okay.
chances of metastasis again is very less. It is
Say 3 centimeters. The chance of metastasis is
around 2 to 3%. Not exact.
correct. It's very less.
So, but so this mass is very unlikely to grow very rapidly or have a metastasis
Okay.
at this time.
No, Aditya, I don't think you can say this, that it is unlikely to grow very rapidly. Rather, the decision of treatment of small renal mass depends on the rate of growth of that mass. Okay, so if it is a less than 3 centimeter mass versus 3 to 4 centimeter mass, in case if somebody decides to keep it on active surveillance, then you look at the rate of growth to take a call when you need to intervene. Yes, what you said is right, that less than 4 centimeters, the risk of metastasis is very low. Less than 3 centimeters is less than 1%. 3 to 4 centimeters is 1 to 3%. Okay, and when Dr. Ganesh Bakshi had asked you about why you want to treat this, or why you want to treat? This is what was expected from you, to say that this is likely to be a malignant mass. The patient has presented with hematuria, so that is why intervention is important. Though the risk of metastasis is low, but theoretically it is there, so it is important to intervene.
Yeah, I think sir has told you all the answers. So everybody please remember that.
So one more question, why there is hematuria?
sir, when RCC is
No, in this case, why there is hematuria? Is it involving a pelvic LSL system?
It is stretching of the vessels surrounding the mass that can be true.
Yeah,
लगता
stretching,
तो है नहीं.
and second important thing is,
So as reported in the CT, this mass is only in the cortex.
yeah,
Ideally, if we see only a mass in cortex and patient keeps on having hematuria, you might even do a cystoscopy. I mean,
Yeah, but even the neovascularization, and if it is quite near, I think it is less than 4 millimeter nearer to the sinus, no? So that
yes,
may be
Sir,
the,
that will,
but it still doesn't bleed many times.
yeah, many times, correct.
मतलब,
sir, only,
unless honestly the PCS is infiltrated, it does not bleed.
yeah.
Correct.
If the PCS is infiltrated, then also we should offer the partial nephrectomy, because
Yeah,
then
you
it's
have to, but the person who has put the pictures, you should have ideally, in that case, put a delayed film showing the contrast within the PCS and the mass side by side. So next time, please remember. I mean, you must be surely having all the films, but make an effort to put all that.
Okay, fine.
So I think let's proceed, matlab. Let's
Sir,
deal with
Yeah.
that partial.
sir, small doubt, sir.
पार्शियल करने के पहले तुमने वो सीटी थोरैक्स का पूछा नहीं, फाइंडिंग क्या है? That is one mistake. EAU 2024, I mean, if you follow the European guidelines, it is written that the quality of evaluation in the very initial page depends on whether a clinician has requested for a CT thorax as a staging investigation. NCCN does say that you can either do a chest X-ray or a CT chest. But that is what is written in the EAU, at least 2024. 2025 will come after a few months, I mean 2 months. Okay. So whoever said partial, remember what Dr. Pankaj sir said. A small 3 centimeter, if it has a high grade, even that can metastasize. Okay. So CT chest is important before you get on to the actual surgery. Generally, I say CT chest and an alkaline phosphatase. We don't do a bone scan in all renal mass.
What about a DTPA renal scan?
So I feel, अच्छा, Rathod sir answer करो.
Sir, with a DTPA scan, CCT shows the opposite kidneys normal.
Wrong answer. Aditya answer करो.
Not needed in this.
Not needed. Why? Answer. मतलब needed, not needed, fine, but you have to justify also.
It would not give me any additional information, sir, doing a radiological scan at this point.
Okay. So the better wording is it is not a mandatory test, because if it is organ confined without metastasis, it is not going to change my line of management technically. What it can give you an advantage on the other hand is it might just tell us to take care while we are giving drugs or using medicines in this patient. But having seen the creatinine, which is normal, on a non-diabetic female, we can skip it.
Fine. Okay. See, we have got multiple cases scenarios, so we can just go ahead and
So
discuss
surgical
whatever is.
procedure नहीं सुनना है ना sir?
No, that will take us separately, na?
Okay, so consider this 3 centimeter mass and I am the patient, I don't want surgery. What are my options?
Other options would be an active surveillance, sir, or we could discuss focal therapy with the
Okay.
patient.
चलो 3.5 centimeter पकड़ो. Active surveillance classic is up to 3 centimeters. फटाफट
We
बोलो,
could
you are in an exam. You have
we
given
could
your theory exam. This could have been a short note also.
we could offer them a focal therapy. We could discuss the option of focal therapy as well, sir. That is something which.
So simple language, ablative therapy. Focal therapy नहीं, ablative therapy. What focus? Okay. So what is available?
Cryotherapy and HIFU are the most widely used.
HIFU.
Cryotherapy
No,
and
hypotherapy.
radio
hypo
frequency
are-
Sorry,
ablation.
radio
probably.
frequency ablation. Yes, sir.
RFA.
RF.
Okay.
So, Aditya, again, as we always discuss, when the question is asked, instead of saying focal therapy, then saying cryotherapy, what is expected is this is a small mass. I would give him the option of ablative therapy by cryotherapy or radiofrequency ablation. the less you let the examiner ask follow-up questions, the more there is a chance to discuss that topic. So, okay,
Correct.
so I can answer this question. What are the options you would want to give to the patient?
So we could discuss the option of ablative therapy in the form of cryotherapy or radiofrequency ablation in this patient.
Yeah, Ganesh,
Okay.
anything else you want to ask on this?
नहीं, वो कश्यपी सर ने पूछा है उधर. How about what
अरे
is the
उसको
role of SBRT?
Dr. Kashyapi, please unmute yourself.
Sir, feel free. What is the role of SBRT? What is the literature on SBRT and small renal masses?
SBRT has been defined for small renal masses as well. Described for small
So-
renal masses. But
So
the
two
exact-
questions. Is it as good as surgery?
No, sir.
Okay, then define fine, but what is the outcome or how does it help?
It is one of the ablative therapies, but the results are inferior to cryotherapy and RFA.
In fact, they are better than cryotherapy.
It is not compared to cryotherapy or ablative therapy. It is compared to partial nephrectomy. So there are reports which have compared radiation to partial nephrectomy, and they have found that the 1-year recurrence rate is marginally higher with radiation. But overall, renal function remains stable in both.
There is a nearly 94% local
99.
tumor control at 5
Yes.
years.
Okay.
Yeah, but if this patient is young, you should go for more definitive therapy.
Right.
So, sir, may I speak, Mahendra?
Yes.
So I just had a debate last year in IR conference. So I gone through literature and I find for the small renal mass up to 3 centimeter, 2-year results are similar for ablation and the partial nephrectomy, but increasing size and with time, local recurrence rate are high with the ablation therapy. So the short-term results are equivalent, but long-term result favors partial nephrectomy. It should be
Okay,
answered
so-
in this way.
Okay, so two
and as
more
the patient
things,
have
right? Yeah, Mahendra, go on.
Go on.
So if the ablation therapy is a very small tumor and he is compliant and life expectancy is good and away from the cortex, they can achieve good margin of ablation, then it is okay. It may be equivalent for the partial nephrectomy. For mass like this, which is touching the PCS, touching the renal vein and other things, ablation therapy may be difficult to achieve complete ablation.
It is not ideal.
With partial nephrectomy, not ideal. So surgery will be the ideal treatment for this patient.
So two more things. Before any ablation therapy, you should take a biopsy of the mass at the same time. So remember that. That is one thing. And secondly, of all the things, whatever comparison, recurrence, residual, three things which we said, importance is the follow-up of these ablative therapies. Follow-up of these ablative therapies is practically difficult. People have been doing MRIs, they have been doing PET scans and still being at loss to find out whether there is a tumor or whether there is no tumor. So these many things you should remember.
Yes.
All the interventional radiologists who do ablative therapies, they are themselves at loss to have a follow-up schedule and how to do it. This is normally seen in practice. After surgery, partial nephrectomy, you are very clear what to do in follow-up. It is as per. Chalo, this I will ask you. How do you decide the follow-up schedule when I'm doing a partial nephrectomy?
So based on the risk stratification, sir. So if it's
Correct. So
low
which
risk,
ones?
So if it's low risk or high risk. So if it is T1,
Which risk stratification you use? Textbook
EAU
mentions 3-4 of them. Leibovich, UISS, S-sign.
SGA.
So see, these are catch questions. you can't just operate and run away as surgeons. You have to know how to check your or monitor your patient later. So don't think that nobody will ask you such questions. And ऐसा कुछ
Even
नहीं है कि
patient will ask.
examiner will just ask questions. Examiner will know what to ask you. So that low risk and high risk is from some guidelines will mention Leibovitz or S sign, something. Okay,
Right.
remember that.
Right.
So let's not go into that because I think you should read it yourself. Otherwise, you will never learn. So high risk has a more stringent follow-up. I will leave it at that. Low risk has a more looser follow-up. So in the first year, it is 6 monthly. Now we go on to the next case.
Yeah.
Sir, one
Bridget,
thing I want to
We
mention
didn't discuss
the-
about the pathology. We didn't discuss about the surgical margins in partial nephrectomy. We didn't discuss about multiple tumors, bilateral tumors.
no,
Maybe
you,
if we have time
Ganesh,
at the end of today's day,
no,
we can discuss
Ganesh,
that.
if you, no problem. If you want to discuss this, we discuss.
नहीं
We
not
have
want
got
to
a
discuss,
multiple.
sir. Let's
We
keep it
can,
on the
even
chat
the next time,
and ये खत्म
even
करते
the,
हैं.
okay. Otherwise, next, we can continue this next time also if it is so important. No problem. Anyways,
sir,
later
one more
on
thing
we
I
can
want
do it.
to one more
Yeah.
thing I want to add regarding the IR and RT. Just like surgery, after removing the specimen, either radical or partial nephrectomy, we will have the very standard scoring system. But after the ablative therapy or RT, other than biopsy, we do not have a scoring system. So again, follow-up scheduling is very, very difficult.
Okay.
This thing I wanted to add compared to how to defend surgery against ablation therapy or radiation therapy.
Okay, fine. One extra point we got. Yeah.
चलो next case,
Who is,
please.
yeah, next case, who is
Thank you,
answering?
sir.
I mean, different people are there, na?
Yeah.
Yeah, Dr.
अभी
Sohail
कौन है?
and Dr. Hamid.
Abhinit
है ना,
and
logged
Hamid.
in है ना?
Dr. Abhinit.
I think whoever is
Hamid.
presenting the next case, please show yourself.
Sir, this is Dr. Sohail Rajpal, sir, from Gangaram Hospital.
Great. Chalo. Whoever is the
Okay.
other person, please join him.
70-year-old
Who is
male
on? Yeah.
presented with
See, listen, you read the history, and if there is a play in the examination, if everything is normal, just say that general examination is normal or whatever it is. Only talk so that we can go faster. Okay?
Yes, sir.
Fine. Go ahead.
70-year male patient came with complaints of mild left flank pain for 3 months. Patient was asymptomatic before 3 months, after which he started developing mild left flank pain, and it was dull aching in nature, non-colicky type, insidious in onset, non-radiating, not associated with nausea, vomiting, fever, relieved on taking analgesics, and symptoms are insidious in onset and gradually progressive. No dysuria, no hematuria, no lithuria, no previous instrumentation, no nausea, vomiting, no history of jaundice, facial puffiness, exertional breathlessness, no lower limb edema, no history of backache, bony pain, weight loss, no history of bleeding disorders, no not on anticoagulant therapy, no history of radiation or chemotherapy, no history of trauma. No
So please
significant
just say the positive history.
nil significance, sir. Personal history also nil significant. And general history, general examination, everything normal. On inspection, abdomen is flat, no significant inspectory findings. On palpation, no obvious palpable lump, no renal angle tenderness, renal output is normal. On percussion is normal, and DRE, anal to normal, normal, sir. DRE is also normal. Prostate grade 1, firm in consistency, smooth surface, non-tender, rectal mucosa is mobile, and rectum empty.
Fine. So as usual, after this, what is your clinical diagnosis and how to go about?
Mild flank pain, sir. So First, at this age, there
Yeah,
can
so
be
just summarize. Yeah.
there can be any reasons like um, stone diseases and nephritis, pyelonephritis, and malignancies or other pathologies.
Pyelonephritis will have fever, no?
Yes, sir. Fever definitely will be there, sir. Other pathology of that organ in that flank region.
So, Brijesh, can you come to first page here, first slide? You go on, Solairaj, no problem.
So left side, so costochondritis, muscular pain.
Okay.
See,
No, there is no any specific finding to like localize the illness, sir, like, in examination as
Okay.
well history.
Sir, as this patient is 70-year-old, my differential diagnosis in this patient would be a stone disease or a hydronephrosis secondary to stricture disease or malignancy, which can be RCC.
So why
Or
not left PUJO?
Why not
yes, sir,
splenomegaly
it can
also?
be a it can be a PUJ also.
Something in spleen.
Mild pain over left flank, male patient है, but ठीक है?
Yes, sir.
What do you mean by stricture causing hydronephrosis?
Sir, any ureteric stricture can be a causing of hydroureteronephrosis.
In a patient who doesn't have history of instrumentation, past stone disease or geocox use,
yeah.
you will still keep a
मतलब,
possibility of stricture?
Then he should have at least history of tuberculosis.
Yes, sir.
So I think instead of really putting yourself in difficult situations like these, instead of giving so specific diagnosis as stricture, you can say that the left flank pain in an older patient could be renal and non-renal. The renal causes could be any obstructive uropathy, any mass lesion, or very, very rarely infective pathology. And leave it there. Obviously, we cannot make any diagnosis based on just left flank pain.
Yes, sir.
And immediately say I would want to investigate and start talking of investigations.
Yes. So I would like to investigate this patient further with blood panel that includes CBC, RFT, LFT, and urine routine and urine routine microscopy and culture, and an extension of my clinical diagnosis. I would like to do a USGKU.
Okay, अगला test दिखाओ please.
So these blood tests are
so in the
very
blood
normal.
test, it is normal or patient is anemic, hemoglobin is less. Please remember this.
Okay.
Because ultimately you are going to deal with the kidney. Yeah. Short ultrasonography.
The left kidney is normal. The significant finding is this in this sonography is showing a well-defined ISO2 hyperechoic, homogeneous, rounded, exophytic cortical mass lesion in upper pole, laterally with presence of mild internal vascularity on color Doppler. It measures about 2 into 1.9 into 1.7 centimeter in size. No hydronephrosis or stone seen. Rest other findings are insignificant. I would like to get a CT scan of this patient for my further evaluation. That is triple phase CT, as the sonography is showing there is a well-defined left kidney mass. That would give me an anatomical detail, functional detail, that the size of the tumor, then its association with the PCS or the renal system, and the vascularity or the vasculature of the kidney, any thrombus is there or not, or any other outside pathology or nodes.
Suppose if I say, I don't want to do anything. It is a very small mass. I will just keep it under observation. What do you what you would like to say?
Sir, as sonography is not a diagnostic criteria of the renal mass, I would like to go further with the CT scan to see the enhancement, if there is an enhancement or not in the renal mass, or is it a benign lesion?
So please answer me properly. I am telling you this is a very small mass, and on ultrasonography it is such a small. I will just keep it under observation. I'll repeat ultrasonography after 6 months. Can I do it, or you still want to do CT scan? And if you want to do CT scan, give me the reason.
I would still want to do a CT scan, sir.
No, you justify, na?
I want to see the enhancement of the mass on the CT scan, sir.
And what?
Sometimes other pathologies like adrenal mass or the underestimated size of this renal mass or retropetal lymph nodes can be picked up with the CT scan better, sir. So we need documentation before taking the patient for active surveillance, sir.
Tell me many reasons. There are many reasons. Are you sure this is malignancy?
Sir, it is a hyperechoic and homogeneous rounded exophytic mass. It can be a malignancy, it can be a benign lesion, sir.
Okay. So again, I'm asking you, see, you have to justify why you want to do CT scan. The same way, it can be angiomyolipoma.
Yes, sir.
So once you do CT scan, that will confirm.
Yes, sir.
And then you're not worried about that. Your line of treatment and follow-up will totally differ.
Sir, if it comes as angiomyolipoma, I would be more clearer for stringent follow-up. But if it comes as a malignancy, then I can explain the patient about the different option we can proceed with.
Okay. Ganesh bhai, or
Yes,
Mahendra,
sir.
how to answer in exam? Such a small mass, what is the need of CT scan? What they should answer?
For diagnostic purposes, it is necessary.
Okay, fine. So that is the most important thing. And then depending on that, they will decide the line of treatment. Whether they want to go for a conservative, whether they want to go for ablative, or they want to go for partial nephrectomy
Active surveillance.
and
Yeah,
active surveillance.
partial nephrectomy.
Fine. Yeah. Okay, fine. So now what you want?
Triple
Amit?
phase CT scan, sir, of abdomen and pelvis.
Okay. Brijesh.
These are the coronal films of the CT scan of abdomen and pelvis, showing right side normal kidney and left side like a mid and lower polar mass of around 2 centimeter in anterior posterior and like in AP dimension. And
Now tell me where it is, lower polar or upper polar?
it is upper polar. At the junction of upper pole and mid pole, sir, it is. And it is exophytic, completely exophytic mass.
How do you define this upper polar or lower polar or mid polar? What criteria?
Sir, anything above the renal hilum
Polar line.
Or
From the polar line, upper polar line, above upper polar line is upper polar, and below lower polar is lower polar line, which is
So I would say these are the Hyler lines, upper and lower Hyler lines. They divide the mid, upper and lower pole.
sir.
Or either you can just put a upper 1/3, mid 1/3, lower 1/3 by equally divide the length of the kidney. But on the CT scan, I think the Hyler line where they cross it horizontally, that make upper, mid, and lower pole.
okay, sir.
So this is not upper pole. I don't think so.
It's at the junction of upper and mid pole, sir.
Yeah, but where is the majority of the part is in the mid pole, I guess. I don't have all the pictures, but whatever I can see.
Yes, sir. It's more of a mid pole mass, exophytic mid pole mass.
Okay.
Yearly branching of renal artery is there.
So let's have a quick revision. What other things you want to see in the CT scan in patient with the renal mass?
Sir, as you said, we should discuss as the TNN classification. First, we have to see the size of the tumor. Then is it exophytic or endophytic? Then the relation with the PC system or the renal sinus. Then the vascularity of the kidney. Then any nodes are there, and then the metastasis or the surrounding organs pathology.
What else? Tumor thrombus and
Tumor thrombus and IVC thrombus, or renal vein thrombus or IVC thrombus.
why looking at adrenal is important? Adrenal.
And enhancement, sir, and enhancement also.
Why it is important clinically or management के हिसाब से?
Adrenal, if adrenal gland is involved, it is T4 if it is in contiguous involvement, and if it is for lower pole tumor, it is metastasis, M1 staging. So adrenal metastasis is important.
Okay, okay. And the last thing you need to see metastatic and the other kidney.
Opposite kidney and solid
Yeah.
organ.
Okay. Okay, fine. So now what next? You want to do any
Sir,
other
I
imaging
would-
like PET scan or
would-
DTP scan this patient?
No, I would not do the PET scan or DTP scan in this patient, as the contralateral kidney is normal. I like looking normal on the CT scan with the normal enhancement. My plan of management would not be changed on doing the DTP scan and the PET scan. PET scan has a no role in primary staging of the RCC.
Yeah, reason?
So since there is high excretion of the
The simple, very low uptake by the normal parenchyma and the renal tumors.
Yes.
That's why it is not contributed in the staging of the primary.
Staging.
Okay.
Yes.
Yeah. And in which patient you would like to do DTP scan? If you not want to do this patient, in which patient would you like to do?
Kidney patient.
Sir, when there is an uncertainty of, or we have to, in the patient with the CKD patients or bilateral tumors or the familial tumors.
Yeah, so you can divide into the two category, absolute, okay, and the relative indication, absolute and relative indication. Okay.
Okay.
Absolute means bilateral tumor or tumor in single kidney, you have to do DTPA. Relative indications, there is any disease which may affect the kidney function in the future, like patient having diabetes, hypertension, chronic renal disease, past renal surgery like nephrotomy, PCNL, anything. You should do the DTPA scan. Okay. When you
Yes,
answer in such a way, examiner will not ask any question about it.
Okay.
Yeah.
Sir, after explaining the condition to the patient and counseling him about the surgical procedure, I would also like to do the metastatic work of the patient in form of chest excess. It is clinically T1A tumor, but as Bakshi sir said that we should do HRCT chest.
So what are the chances of metastasis in this case?
Sir, it's very unlikely, very less chances in this size of tumor, less than 1%.
Okay. So say it is less than 2 centimeters, so chances is less than 1%. Like that. Okay. And what will be the management now? You want to,
Sir, as the age of the patient is 70 years, I'll counsel him about all the procedures which can be done for this tumor, either in form of the nephron sparing surgery of or the ablative procedure or the active surveillance. I would counsel him about the advantage of the nephron sparing surgery over the ablative surgery and the recurrence rate of the nephron sparing surgery as compared to the ablative procedures. As the recurrence of the partial nephrectomy patient, recurrence of the tumor in the partial nephrectomy patient is 2 to 4%, and in the ablative procedure it ranges from 5 to 20%, like 3 to 10% in cryotherapy and 5 to 20% in radiofrequency ablation.
and what about active surveillance?
So active surveillance I can offer to the patient if he needs, but as there is no comorbidity, as in patient is look like fit for surgery, I would explain him. I would explain him for the partial nephrectomy.
Why
Dr.
are you
Kashyapi,
hesitating?
can you
Yeah.
guide them? Yeah, Mahendra, you were saying something.
Since I was asking why is he hesitating to offer active surveillance in such a small renal mass?
Yeah.
Sir, I can offer him active surveillance, but as there is more chances of complete removal of tumor with the partial nephrectomy as compared to active surveillance. So
So that means you don't understand, you do not know what is the theory behind active surveillance in any cancer.
no, sir,
What is
active
the logic?
since the uh, small renal masses have very less growth per year, and there is very less chances of metastasis. We offer the active surveillance in the patients who are comorbid or not fit for surgery. And
No, that is called watchful waiting. Then that strategy is called watchful waiting. So that means you do not know the difference between the active surveillance and the watchful waiting. Please read it.
sir, no, sir, active surveillance, I know whenever the tumor is growing, I have to intervene. I will explain the patient about that.
No. But
So what will be
what is
the
theory
rate
behind
of,
it?
Sorry, sir.
Sir, what did you say?
no, what I wanted to know is what will be the rate of increase in size of this tumor per year? How much it will
Less
increase?
0.3 mm per year, sir.
So suppose if you go for an active surveillance, at what size you will like to operate?
Greater than 3 centimeters.
So how many years you are expecting?
10 years.
No.
No, sorry, 1.5 years. As the tumor is 2 centimeter to 1.5 years.
So 2 to 3 years, 3 years when you will be intervening. Correct?
Yes, sir.
If it is increasing. Right?
Yes, sir.
So it is not a very long period.
Yes, sir.
And then that time, if the patient, you have to understand the psychology also. No? If the patient is very willing and he is understandable, then it's okay. Otherwise, all the 3 years or 2.5 years, he will be under tension.
Yes, sir.
Okay, so what you will like to do in this
Surveillance-
case?
Yeah. So
Yeah,
active
yeah,
surveillance
yeah, sir.
is a strategy which should be applied with the applied wisely actually. A well-informed and compliant patient who understand this strategy very well, that it is only applied him or her to avoid the treatment-related complication without compromising the survival or oncological survival. Okay, and he needs some strict follow-up. In surveillance, they need to go with the biopsy of the kidney. If there is any aggressive tumor variety, surveillance is not offered. Otherwise, conventional clear cells or surveillance can be offered. And they should be ready when there is a sign of disease progression. Then they should ready for the intervention. This is called active surveillance. Okay. So well informed, compliant, and understand the well patient can be offered such a strategy. Not every patient.
Yes.
Okay, but this is the type of treatment you should always mention and know what is it. Watchful waiting is you said life expectancy is very less. He's very comorbid. Okay, like that.
Yes, sir.
Now tell me, how are you going to what are you going to offer this patient?
Sir, I would offer this patient nephron sparing surgery, which can be either in the form of open or minimally invasive laparoscopic or robotic surgery.
Okay, okay. So which ischemia you want to do this surgery? Warm ischemia, cold ischemia, super selective ischemia, or no ischemia?
Sir, as sir, at our center, we usually do the uh, selective ischemia or super selective ischemia in these type of tumor that are more of a cortical tumor. Otherwise, the renal artery is clamped, and when we more deeper tumor, we usually clamp the renal artery and then do the excision of the tumor with the infrared sonography guidance to demarcate the tumor.
Yeah, but surface tumor, do you really want to do any ischemia
In this case,
for surface tumor?
no, sir.
But this
In this
appears to
case,
be
it's
a tumor
very
just lying on
superficial.
the hanging from the surface only.
So it can be done with with off clamp technique also, sir.
Okay. So how much ischemia time is ideal?
Warm ischemia time should be less than 25 minutes. That can be extended up to 35 minutes.
Cold.
And cold ischemia time is should be less than 35 to 40 minutes, ideally.
Yeah, up to 45 minutes, around maximum to 1 hour. Okay. And the type of cold ischemia? But not type, the methods of cold ischemia?
Sir, there are three ways of cold ischemia. We can inject the cold saline through the ureteric catheter in the ureter, or we can uh, do the surface cooling or intra-arterial injection.
Next.
These I know the cold ischemia techniques. And
Sorry?
warm ischemia. The three type of cold ischemia, sir. Through the ureteric catheter, we inject the cold saline or the surface cooling with the ice flush or intra-arterial injection of to
So
reduce
which is
the
the most commonly used?
surface cooling, sir.
Okay. So what temperature you like to keep surface
4
cooling and
degrees,
why?
4 degrees Celsius.
4
So,
degree.
17 to 20 degrees.
no, sorry, sir. 20 to 24 degree.
Yeah, so surface cooling is is most commonly done because of it cools the renal cortex, and that's supposed to be a most a metabolically active part of the nephron in the cortex. So that's why it is most commonly used. And other things are technically very difficult and not so this thing. They can achieve good surface cooling by rotary catheter and arterial. Arterial is good, but sometimes it can also lead to hypothermia of the body. Okay,
Yes.
and renal
Yes.
artery thrombosis. So that's why surface cooling is has the least complications, maybe no complication with achieving an effective uh, cold ischemia. Okay.
Yes. Yes.
Yeah. Okay.
Sir, ideal temperature 17 to 20 degree or what, sir?
Yeah. It is written in the Campbell. Whatever you are telling, 10 to 20 degree Celsius. To achieve this temperature at the surface of the kidney. Okay.
Fine.
Uh,
Okay. British just show the histopath report.
Sir, we are not discussing surgical step. We are not discussing NSS or the
No,
thing.
not surgical step. I just
Yeah.
just because histopath report is little different. That's why. Nothing else.
It is oncocytic, sir.
Huh.
It is
So no, do you want to ask any question on that?
no
For the
what follow
how
now,
follow up
not
or anything?
follow up. No, only follow up or some CT scan findings which are sensitive for oncocytoma. It is benign or it is malignant.
There is on the CT scan there is like we can't differentiate precisely on the CT scan that either it is a oncocytoma or the RCC. So, but there is a central stellate scar on the CT scan, and there is spoke wheel pattern seen on angiography in the oncocytoma.
As well as chromophobe RCC.
Okay. Fine. Kashabi, you want to ask any question?
Nothing at the moment, sir.
Okay, so then we go to the next case.
Sir, so
Yes,
doesn't need any.
sir, I want to ask one question, sir. What should we answer in the exam about the metastatic workup in clinically T1A tumor, like in this patient? Should we tell chest X-ray or HRCT chest?
See, both
We
are
discussed
accepted.
it.
Yeah.
Another
So
easy
in this
answer I will
case,
tell you. I would say CT chest and then say it is my institutional protocol.
Okay, sir.
Yeah.
And CT chest is anyway a safe answer. Now this you are asking here because it is a very, very small tumor. So it doesn't matter actually. Questions more are how much margin you will cut through. You are doing a partial nephrectomy.
This case we
Answer
can
that.
Quick answer. Quick answer, please.
Sir,
Amit, quick answer.
R0 resection we should achieve that is based on the
I asked how much more margin you will cut. R0 is obvious here.
1 cell thickness margin.
Okay. I mean, that is a very bookish answer. You say a small margin, but it can be as low as 1 cell, whatever. Because we do enucleation. What are the methods of resection?
Sir, it can be
So might as
enucleation,
well.
it can be wedge resection, it can be heminephrectomy, and
So it can be enucleation, resection, or it can be enucleoresection as a combination. These are the three answers. So, Mahendra, what is left? How do you achieve hemostasis after cutting?
Sir, once the tumor is out, I will do the medullary stitching, and once that is done, and I'll unclamp the renal artery and see if there is any bleeding point.
You
Then
see, everybody must have seen some partial nephrectomy happen, either open or whatever, lap, robotic, something. So you have some plan in your mind. You will have, when this type of question is asked, you will have to answer something. We do a bulk closure or we do a individual closure. If there is a calyx cut, then we would take it separately or whatever, something like that. Always try to, Pankaj sir said that you stratify your answers in such a way that the examiner doesn't come back to you. Okay, remember. So that is with inner layer you are taking.
Yes, sir.
So I would answer like this. In the inner layer, I would do a individual closure of the blood vessels. If there is a calyx cut open, maybe I will suture it with running continuous suture, 4O or a 5O PDS in single or a double layer as I'm comfortable. That's it. And then I'll go to the outer layer. Outer layer, what you will do? How will you manage that? You will leave it open? Will you release the clamp and then suture?
We like at our institute, we release the clamp and then see if there is any bleeding point, or then we take a suture. Otherwise, we just put some Surgicel and uh, keep it there.
You don't do outer rhinography?
Sir, if the like margins are big, then we do the outer rhinography. Like in this 2 centimeter tumor, 1 stitch is enough after placing a surgery. Sorry, sir.
Single layer suturing, you want to say?
Yes, sir.
Okay.
What suture material?
Sir, PDS. PDS 3040 VT.
And single layer, you're saying?
And yes, sir. And for the parenchymal, we usually take CT1 sutures.
CT1 is a vicryl suture, if I mistake not, right?
It comes in a PDS form also and vicryl also, sir. Both.
So CT1 is a needle?
Needle, yes.
So sir asked you suture, so answer suture.
Have you heard of barbed sutures?
Yes, sir, barb sutures. The medullary stitches we usually take with barb sutures, sir.
And what about the outer rhinography, if it's required?
With the vicryl sutures, sir.
Okay. Actually, we would use a barb suture even for the outer layer, and the inner layer we would do with a PDS or a vicryl, whatever you want, or even the barbed also, inner layer, inner rhinography. So as Dr. Ganesh explained, either you suture individually vessels and the pelvic health system, or you do an inner
PDS.
running rhinography.
Yeah.
You do
if you are using a barb suture, then you are do a complete running suture.
Rhinography, inner layer, and a second layer for the outer raphy.
Yes.
Sir, as this tumor is hanging out of renal cortex, can we just do only one thing?
You can do, but this question was not specific to this case. So when you were asked that what are the methods of suturing, you should say methods of suturing. Don't limit or narrow your own outlook in the exam. We don't mind, but you will be judged accordingly.
Yes, thank you.
What is the drawback of barb suture in doing rhinography? Though they are very good in holding tissue and applying traction. What is the drawback of barb suture?
Quick.
Sir, if the margins come positive and we have to go again inside, then it would be difficult.
And it is easy with the
send
PDS
for a frozen.
vicryl?
You have an institutional protocol of frozen every case.
For the barb suture, sir?
No.
Frozen is always for the partial nephrectomy.
No frozen. No frozen, sir. No frozen.
Then why do you say you have to go in again, vagere? How does it matter? So I think the probable simple answer was that when you're pulling the barb suture, it can be a cut through.
Okay.
I don't know.
And it would
Mahendra,
be
what was your answer?
Cut through. The same, sir. There is some rule of pulling the barb suture in the same direction. It comes out, not perpendicular to the tissue, because the tissue will cut through, and that tissue damage will be very actually big and deeper and difficult to manage, at least in NSS. Okay. So this is the drawback of using barb suture in NSS.
Okay.
So the histopathology has come oncocytoma.
Yes.
Yeah, I was going to follow up only. I think all three things we discussed about CT findings, the 9 malignant, only follow up.
Are you happy with the biopsy report, whatever is shared?
Sir, on CT scan, since the tumor is well encapsulated and it is heterogeneous, that is suggestive on CT scan both of RCC and oncocytoma. We can't clearly distinguish on basis of CT scan. We need histopath only for
No, I asked
confirming
you a
his
question about
oncocytoma.
the histopath report. Are you happy with that report? What it says, suggestive of an oncocytoma. This should be reconfirmed by doing further IHCs.
Okay.
So it is suggestive of an oncocytoma.
Yes.
So a good pathologist would ideally do further IHCs and confirm, or somebody would say advise further IHCs for typing.
Yes.
So you should pick up that key. Don't accept that suggestive of an oncocytoma. You should have a very clear-cut diagnosis.
Okay.
Absolutely.
Okay. Yeah.
Because when you are seeing histopathology, the diagnosis should be the most certain diagnosis.
This suggestive means he is not committing to anything.
Yeah.
Pathologist.
Actually, thank you. I will now go and talk to them regarding this.
Ask them to do further IHC studies.
No, I just read the report. I was very happy. I told the patient, but what you are saying is absolutely, it makes sense. You know, suggestive means what? IHC and okay, I'll go where. So these are the points we learned. Thank you. Okay.
Thank you.
So shall we go to the third case?
Next case. जल्दी करते हैं 11 बज गए हैं।
जल्दी चलो ब्रिजेश
Sir, can I start?
Yeah, start.
A 74-year-old male presented with complaints of mild pain over left flank since 1 month and hematuria since 4 days. My patient was apparently all right 1 month back. Then he started complaining of very mild pain over the left flank pain, which was dull, aching in nature, insidious in onset, non-radiating, gradually progressing, not associated with any nausea, vomiting, fever, no specific aggravating and relieving factors. Patient also noticed passage of the blood in a urine since last 4 days. It was sudden in onset, painless, non-progressive, self-limiting, and hematuria is complete, intermittent, associated with passage of amorphous clots. Then, sir, there is no history of dysuria, lithuria, no history of colicky pain at the time of hematuria, no history of previous instrumentation or catheterization, no history of nausea, vomiting, no history of jaundice, facial puffiness, exertional breathlessness, lower limb edema, no history of backache, bony pain, weight loss, bleeding disorder, anticoagulant therapy, or blood transfusion in the past. Then past history, patient is a known case of hypothyroidism on thyronome tablet 50 micrograms since last 10 years. Family history and personal history is not significant. Then I would like to do general examination. In general examination, I would like to check vitals of the patient. In this patient, general
I think we will
examination.
skip general examination. Go to
Yes,
whatever.
sir. Per abdomen examination, abdomen is flat, centrally placed,
So
inverted.
it's normal. Go ahead. Go ahead.
Sir, left angle tenderness is there, and left angle tenderness in palpation, and left kidney is palpable. Wrist examination appears normal, sir. And percussion.
So if left kidney is palpable, you stop there. So it is bimanually palpable, it is ballotable, ये सब चाहिए इधर.
Yes, sir. Sir,
I am saying it to hurry, but then if something is positive, you need to pay attention to that. And if you have not typed that, then you should ask that question.
Yes, sir. Sir, I would like to know whether it is ballotable or bimanually palpable.
So what is the significance of ballotable only versus bimanually palpable?
Sir, in palatable palpable kidney. It is pedicle structure with the small mass. When a thrust is given from the
So
below,
that's
it
the
will be
principle of palatable. It is
palatable.
a relatively smaller mass.
Yes, sir. And then, sir, I would like to summarize my case. In 74-year-old male patient with left flank pain with hematuria with known case of hypothyroidism, and in local examination he is having left flank fullness with tenderness. So I would like to keep the renal stone urolithiasis with cystic disease, renal mass with upper tract urothelial carcinoma, and lastly I would like to keep renal tuberculosis as my differential diagnosis in this case.
So renal stone with mass with
No, sir,
whatever cystic something.
renal stone disease first, then sir renal cystic disease, after that renal mass, after that upper tract urothelial carcinoma, and after that I would like to keep sir
But ये
renal
renal stone only में palpable mass.
sir if it is
मतलब
obstructing
you are
the
going to say it
kidney,
is xanthogranulomatous pyelonephritis.
sir, but as a
I don't know. Let's ask Pankaj sir. And I'm slightly
Very unusual to have a large palpable kidney because of stone disease, though not impossible. But again, you see, in an older patient with palpable kidney and hematuria, I think you should first keep renal malignancy and then go for other diagnosis.
Okay. Yes.
Okay.
Yes,
Even the
sir.
pain is not very classical of a stone pain.
Yes. Then, sir, I would like to do routine laboratory investigations, urine routine microscopy, then, sir, complete blood count, renal function test, serum electrolyte. Sir, in this patient, the CBC, renal function test, urine routine, and other investigation, liver function test appears normal. Only HbA1c is 7, sir. After this, sir, I would like to do the sir, urine routine appears normal, just hematuria in the urine routine. And sir, after this, I would like to.
ये normal मत बोलना urine routine. After saying hematuria, please.
Okay, sir. Sorry, sir.
वो
Hematuria.
अभी दूसरे केस में सोनोग्राफी में भी लिखा था both kidneys are normal and नीचे लिखा था mass in the left kidney.
Yes. Yes, sir. Sir, I would like to do ultrasonography of abdomen and pelvis for this patient now.
वो दिखा नहीं रहा है वो.
Yeah.
He is not agreeing to you.
Sonography was not there with the patient. The patient came from outside.
Okay.
So what was
then,
done?
Sir?
The patient came with a CT scan.
Yes, sir. Sir, then next investigation, I would like to do contrast enhanced CT scan of abdomen and pelvis with IVP, with angiography, and with HRCT, sir. Sir, this axial CT scan of abdomen, these films are look like plain films in which right side of the kidney appears normal. On the left side, the shape of the kidney is distorted. There is a solitary large mass seen with the heterogeneous enhancement with sir with that lesion present mainly in hilar region, medial side of the left kidney, sir. Then for further detail, I would like to see another films. Sir, these films look like a contrast enhanced film in which right side of the kidney appears normal. Left side of the kidney there is a solitary mass around 8 centimeter into 5 centimeter appearing almost appearing from the lower pole of the kidney going into the pelvic calyceal system with heterogeneous enhancement and some patches of necrotic patches seen inside. Perirenal fat appears normal, and medial aspect also shows some heterogeneous lesion, most probably, sir, it may go into the vessels. Then, sir, there is no obvious lymphadenopathy seen.
Going
And,
in the vessels means?
Sir, in the hilar structures.
Okay.
Which
So
artery?
medially, the mass is extending medially.
Medially, yes, sir. In the
I mean,
hilar region.
and the vascularity seen can be just normal vascularity around the renal mass in RCC. RCCs are angiogenic. The HIF hypoxia causes angiogenesis, basically.
Yes, sir.
Hypoxia-induced factor. HIF is hypoxia-induced factor.
Yes, sir. And, sir, no lymphadenopathy seen.
What is
something you missed in the CT scan?
Sir,
You described the mass very well.
Sir, rest of the solid organs of the abdomen appears normal.
Something abnormal
something else.
you missed. Just go to the next picture, which you were describing. Yeah, over here. In the same picture.
Sir, heterogeneously enhancing and having
Focusing on the mass.
Neck.
Focus also on the vasculature, which is again a part of reading CT scan in the renal mass. This patient having retroaortic renal vein.
Yes, sir.
And in this case, you will not see the classical renal vein thrombus. I think in the second image, the center image, the projection of the tumor mass is probably going into the renal vein, which is retroaortic, and that is bulging around the lateral aorta. I don't have the full, it is not there, but probably it can be a renal vein thrombus, tumor thrombus.
There seems to be a simple renal cyst also.
Yeah,
in the first image.
left side.
In the first image, a large renal cyst there.
It's slightly at the just below the upper end.
Yes.
So I will take from your
and pancreas
description.
is seen in that section.
Yeah. So what I can assume with your description that you have memorized the CT scan findings in detail very well, but you missed the other important thing.
Again, if you see around the renal mass, there is a lot of vasculature, even in the third image. There's small shining dots everywhere, laterally, medially, on the top,
So again,
anteriorly.
Sir,
again, they indicate thrombus in the renal vein.
They indirect evidence, we don't know.
Yeah.
And we don't know why, because these are representative images. Remember that thing.
Yes, sir.
It's a very safe justification. I have not seen the whole CT scan.
Okay, sir. And, sir, HRCT also.
Yeah, read.
Sir, there is evidence of an abnormal, large, well-defined soft tissue mass lesion seen involving midpole of the left kidney. It measures approximately 5.3 into 8.7 into 5.8 centimeter. On dynamic post-contrast study, the mass shows intense heterogeneously enhancement on both arterial and late arterial phase with relative washout of contrast on venous phase, as well as a peritumoral neurovascularity. It shows central areas of hypodensity and hypoenhancement suggestive of necrotic areas. The mass is predominantly supplied by mid-polar branches of the left main renal artery. An accessory renal artery is seen just inferior 7 mm to the main renal artery and seen supplying the mass and lower pole. The distal segment of the left main renal artery and accessory artery are seen partly encased by the mass. However, both the renal artery shows uniform contrast opacification. The mass is seen extending into the left renal vein, causing the dilatation for a length of 8 cm, suggestive of tumor thrombus. Distal segment of left renal vein adjacent to the IVC shows uniform contrast opacification. There is evidence of another accessory renal vein draining its upper and lower pole. It is seen traversing posterior to the aorta and draining to the main renal vein. There is evidence of large exophatic simple cyst arising from the upper polar cortex measuring 5.8 into 4.5 centimeter. The residual left kidney shows uniform renal parenchymal enhancement. No evidence of radiodense calculus or hydronephrosis is seen. The CT urography image show mass infiltrating the mid-pole of the calyx, partly encasing as well as displacing the renal pelvis. The right kidney appears normal in size. Position shows smooth cortical thickness. Sir, should I ask for renal score in this case in which already mass is extending into the renal vein?
Not needed.
Yes, sir.
Renal
Anyway,
scores in small renal masses usually.
Yes.
anyway, thrombus involvement is not in the nephrometry score. Then how we are going to
Yes.
categorize it?
Yes.
So how will you treat the patient?
Sir, I would like to counsel my patient regarding the diagnosis, staging of the disease, as well as I would like to give the options available for the
So what
treat.
is your option?
Sir, in this case, this tumor is staged into T3A, N0, M0. Sir, though I have not seen the HRCT, so I am considering it is non-metastatic. Then, sir, in this case, there are laparoscopic, robotic, and open radical nephrectomy with
I think in the first case only, Pankaj sir said that why don't you say which procedure is to be done and then discuss the approach.
Yes, sir.
If examiner asks you, if examiner wants you to put your effort into approach, then put it.
Yes, sir.
I understand a lot of people are doing lab, robotic, everything, but is it really needed in the exam? It may be needed if the examiner asks you.
Sir, I would like to go for
तो चलो, you describe robotic, whatever, radical nephrectomy on the left side, complete. Describe. हाँ, ऐसे ही होने वाला एग्जाम है यार, मेरे जैसा खड़ूस रहेगा तो ऐसे ही होगा. चलो.
Again, the
Whatever you are
best
saying.
thing is just say what surgery, what you are going to offer. And let the examiner ask, and then you answer that yes, sir, in our institute, we are doing this procedure. If I have to do, I'm well versed with this simple procedure. If patient is asking for latest advanced technique, then I will call my senior who is regularly doing it.
Yeah, I would have said in exam, even now, if you take my exam, I will do open, left, radical, nephrectomy.
Nephrectomy.
At the most, if I'm smart, I'll say with which incision.
Yeah.
That is it. If examiner hits me, okay, I understand, but you describe laparoscopic, then I'll say laparoscopic. That's it.
Fine. Maheshwari ji, you are
So
going
what
to be
incision you will
examiner.
plan? What incision you will plan?
Sir, I would like to go through the midline incision in this case, sir, because midline incision through transperitoneal, because tumor mass is medial, it is 8 centimeter mass, as well as there is a abnormal blood vessels. So transabdominal midline incision will give more exposure and better control of the vasculature as compared to the supracostal 11th rib.
Okay, so you explain the steps, how will you reach the kidney and your site of exposure.
Sir,
sir,
I would
I
like
want
to
to
give midline
correct him.
incision, open the abdomen. After that, I would like to do a Mattox maneuver, and I would like to rotate the left colon medially as well as right colon. After that, I would like to give the incision along the inferior mesenteric on the mesentery.
Right
to
colon
open-
क्यों हाथ लगाना है
Why
तुमको?
right colon?
Sir, even if I have to expose the right renal vein, so right vein and renal artery for the clamping, then I need the exposure.
What does your CT picture say?
Sir,
There is whatever 7-8 centimeter tumor thrombus in the renal vein,
renal vein.
and there is a distinct 1.5 centimeter of renal vein available before it actually merges into the IVC.
Yes.
Why are you wasting time on the right renal vein? We understand
Sir,
you want to show off as a surgeon.
Sir,
Why should we allow some show off?
Sir, if I am not able to get the hilar structure, so I need the space.
The hilar structure is on the left side. We are talking about hilar structure of left kidney.
Sir, even sir, in this case, there is a retro-aortic venous channels which is encasing the aorta and going to the right renal hilum. So if the tumor is inside that, and for the better control of bleeding,
Okay, as he talks, please show that last CT scan picture. Go on.
Rahul, one suggestion to you. You may be right in what you have said, but if the examiner is pushing you in some direction, be a bit malleable.
Yes.
You see, it is
A
very
bit malleable,
clear
and
that
see the picture now. Let us forget about being malleable. If you see the
you see,
aorta and its lateral
definitely you
border,
do not
where
need
is the
a right
thrombus
side
stopping?
exposure in this patient.
The thrombus is stopping well left side of the aorta. So even if it is a retro-aortic vein, here there is one big advantage to you, that I am okay with the midline incision. In fact, you mobilize the colon, you go to the vasculature, the artery here will be seen up because of this anomaly. Usually the artery will be slightly difficult in a midline incision if it is normal with this kind of hilar vessels around which are shining. But in this case, your artery is going to be right there. Once you take that artery, once you take those two single renal artery, which is branching, most of these collaterals will reduce. The next thing is there is a vein which is left side of aorta. You got it.
Yes.
So I don't disagree. Unnecessarily don't say right side. That's why I say don't show up.
Yes, sir. Yes.
So that would be necessary if there is a big IVC thrombus going subhepatic.
IVC thrombus, and you need a control of everything. You need a down control, up control, opposite control.
But not in this patient. In this patient only you have to be restricted to your side of surgery.
Yes, sir.
Okay, I think that should be enough, sir.
Yeah,
that should be enough. Suppose if this same patient has a solitary right lower lobe metastasis, what is your plan of action?
Sir, metastatic.
Yes, HRCT or a CCT chest, 2.5 centimeter right lower lobe lung lesion.
Sir, if solitary lesion is present, then solitary functioning kidney. Sir,
solitary functioning kidney किधर है? दो kidney था इसको.
Okay.
In the lung, in the lung.
In the lung, sir, then
same patient with a CCT chest showing right lower lobe lung lesion 2.5 centimeters. Metastatic.
Along with the radical nephrectomy, I would like to do metastatectomy also for that single lesion, sir. With lymphadenectomy. And
so why will you not do अभी जो radical nephrectomy only क्या है तब lymphadenectomy का role क्या है?
Sir, if during the operation we are able to palpate the lymph nodes, as such on CT scan there is no lymph node seen. If we are able to palpate the lymph nodes, then we can go for the lymphadenectomy, because overall survival, 5-year survival of the patient and progression-free survival is less as compared to the Sir, benefits of the lymphadenectomy. Lymphadenectomy is more comorbid and it will not give more survival benefit.
I didn't understand. मतलब करने का कि नहीं करने का?
Sir, if lymph nodes are palpable on table, then we can go for the lymphadenectomy.
Okay. So either lymph nodes are palpable or lymph nodes are visualized on the CT scan, or there are some other criteria in other publications. It's a large mass. There is a lot of necrosis.
Large mass greater than 10 centimeter, T4 lesion, then we can go for the lymphadenectomy.
These are the certain conditions when you can go for lymphadenectomy. As far as the lymphadenectomy is concerned, many times it does not change the prognosis, and hence
Yes.
there is a debate about the lymphadenectomy. Okay, but remember, there is a EORTC 30882 which had studied and said there is no benefit of lymphadenectomy in renal cell cancer. But the catch point in that study of EORTC was the renal masses inclusion criteria was only 5 centimeters. So till 5 centimeters, you can code that trial. Beyond 5 centimeters, there are umpteen number of publications which say, depending on the necrosis, the lymph node seen on CT scan, palpable in the surgery, thrombus, and all these things, then you can do a lymph node dissection. Classic lymph node dissection was from the diaphragm to down. There is a UCN a few years back which says the lymphatic drainage of the kidney, right and left. The left predominantly is para-aortic and pre-aortic to some extent, and very small 3 to 5% inter-aortic cable. Whereas right comes to inter-aortic cable in a big way, at least 13-14%. Remember that.
Yes.
The main question was different. With a solitary lung mets, you said you will operate and you will operate something.
Sir, with radical nephrectomy, lymphadenectomy,
And a metastatectomy.
Metastatectomy.
And what you will do?
Sir, after that, I would like to see the histopathology report, and then
Okay.
I would like to go for
Clear cell renal cell carcinoma, ISUP grade 3, kidney ka stage T3A with the lung metastasis is backside positive. It's
Then,
clear
sir,
cell RCC met.
Then, sir, I would like to give adjuvant chemotherapy in the form of tyrosine kinase inhibitors or
Adjuvant chemotherapy.
Sorry, immunotherapy in the form
of
sir, checkpoint inhibitors like CTLA4 and PD1 as well as PDL1 inhibitors.
Okay. Immunotherapy in the form of PDL1 inhibitors थोड़ा सा contradicting हो रहा है कुछ किसी ने तेरे लिए help के लिए answer लिखा है.
Sir,
Can you quote the trial?
Pembrolizumab.
I think Paras is very generous. Paras, you can tell us the trials. You are typing anyways from somewhere.
Sir, checkmate trial for
He is written for you. So what is the inclusion criteria of Keynote 564?
Sir,
I'm asking you this question because it is related to surgery. Keynote 564 is about adjuvant therapy in renal cancer. So it is about surgery. So Paras has written.
Paras, you can just
You can
unmute
talk
yourself.
also, we don't mind, Paras.
Also
You
talk.
can come
Yes,
in and
Paras.
talk. T2 grade 4 he has written and up. So it also includes N+. It also includes patients rendered M0, like what you described. You are right, but you described that. So these are called patient rendered M0. So some more statistics I need. How much cycles you give?
So we usually give 11 cycles.
So we give 17 cycles. So
where
what
is
is
this
the
11
absolute
coming
risk
from?
reduction?
Sir, I don't know exactly.
Read it then, no problem. You have to read this last line. Absolute risk reduction with the pembrolizumab. Okay.
Yes.
I think that kind of any next patient.
Yeah.
Yeah,
Vijay.
we can stop also. 11 बज गए.
Okay, then there are two interesting cases. We'll finish it fast next time first, followed by remaining case. It means the new subject. Okay.
Sure, sir.
अभी भी एक करना है तो कर देते हैं.
Okay, then it's a
It
short
depends
case.
on everybody. Yeah.
Yeah. Brijesh,
Yes, sir.
the last one which I gave you, or even Dr. Ganesh Bakshi. I think
नहीं
Ganesh
सर
Bakshi
वही
का
खत्म
case.
करते हैं, वो नेक्स्ट टाइम लेते हैं, वो बिना ही नहीं anyway.
हाँ, ठीक है. Brijesh, you only give the history in short.
Yes. "70-year-old male patient had underwent right radical nephrectomy 2 years back, now came with a swelling over right flank region. It is not obvious in this picture, but there is a mild fullness over the right flank region. So previously, the histopathology report of the right radical nephrectomy showed clear cell carcinoma, grade 1 with clear resection margins. And sonography sonography suggested that there was a 5 cross 12 centimeter mass over right flank region. Again, so we had done a PET CT scan. PET CT scan could not pick up the mass, but there was a lytic destructive activity over right rib.
So it was saying like actually it is a 5 years. Patient was operated in 2019. It is not a 2 years old. He was operated in 2019, and he had come for a follow-up almost for 4 years. Until that time, there was even the CT scan was not showing any recurrence or anything. And now he came with a mass in the right side of the posterior part of the chest. Yeah.
So biopsy from that small bit of the right side of the rib also suggested there is a clear cell carcinoma of foci.
We have done IHC also, and it is also confirmatory. Yeah.
Your pathologist writes left lower limb.
No, I know. It was, we discussed, it was the lower rib.
Okay, next what?
Yeah. Any six of you, anyone can answer.
Sir, we have to.
Can we see some image?
I have already given, na? Brijesh?
CT images were, I think, not there.
I had given you. I have already.
Okay,
In the evening, I
will share.
forwarded you.
Yes.
Anyway, read the report. Show us the final impression.
So it is a lytic destructive lesion with metabolically active soft tissue component along the length of the right 11th rib, consistent with known metastatic disease. This is the main finding.
It's a big thing, 10.8 by 5.8 centimeter.
Yeah, actually, I have already forwarded him the.
Yeah, I will share, sir.
So, chalo, what will you do? कौन कोई नहीं है पूछने को.
Basically, this is for, I think, management. What is the latest
Yeah,
management in
management
this?
directly. बोलो. So again, same thing. Looks like a solitary.
Yeah. So, Ganesh, whether you will call it a metastatic disease or it can be recurrence, what you will call it?
Sir, metastatic, I think so, because it is in the whatever
In the rib.
fifth rib, but big lesion.
Yeah. So this is what
But sir,
you have seen.
what is the last CT scan was done? The duration with the last CT scan, because this is huge. That means at least 6 to maybe 10 months or something like that. The time
No,
gap
no.
between
Last
the two
CT was
images.
done 2 years back. 2 years back.
Yeah, that's why it was missed.
Yeah, maybe.
Okay.
So it is a solitary metastasis which is big in size. In renal cell carcinoma, your treatment should be surgical when you can render the patient R0. So with the help of thoracic surgeon, probably we should plan complete resection.
Okay.
And probably with the size, there is a SOS need of reconstruction of the chest wall. So
You may need
you will
to
have to
resect
plan that
one rib
surgery.
above and below.
Yeah.
So is there any
Sir,
role of chemotherapy or immunotherapy before doing this surgery?
So before का rule इतना खास नहीं लगता है if the lesion is resectable. If somebody says that it is unresectable, then there is a role of immunotherapy or TKI plus immunotherapy. Depends. But otherwise, if it is resectable, resect and then start something.
Yes.
But sir, if we can achieve R0 with good margin, then again there is no need for any therapy. We can wait for the further recurrence in future.
I agree, Mahendra, but then again it goes in the keynote 564 only.
Yeah.
So
But
that's
looking
still
at the
with
size of the
today's
lesion, it might be worthwhile to give rather than
yeah,
waiting.
no, but it goes in keynote 564 because with surgery you will still render it M0. So I would not look at size also. If with today's whatever evidence available, keynote 564 is the only trial.
Yes.
Okay.
Yes, sir.
So we
Anything to
should.
discuss?
No, I think that this is only that what is whether the role of any chemotherapy or only the surgical management, and whether you call it a recurrence or you call it a metastatic. Only that was a difference.
Sir, it is distal recurrence with metastasis only. Either local recurrence or distal recurrence. So it is metastasis.
Okay. Okay. Fine. Okay. Kashyap, you want to add anything?
No, I'm fine, sir.
Oh, okay. Then your case we will discuss first next time, Ganesh, and then we'll continue with other things.
तो सर सब है कश्यपी सर है तो वो भी ले ही लेते हैं बेटर
Okay.
I
Okay,
mean
fine.
Take it.
Fine. Brijesh,
महेंद्र भी ताजा लग रहा है तो he will
Mahendra
go for
Pal.
questions.
Yes. Brijesh. किधर गया ब्रिजेश? लगा दे. हाँ.
Okay.
Yeah. Brijesh, you can read, no problem.
Yes, sir. So, 43-year-old male patient came with a complaint, one episode of pain over right flank region. No any complaint of immature or anything. Had past history of diabetes and hypertension, no any addiction, non-smoker, non-alcoholic. Family history is insignificant. So clinically, abdominal There is a palpable mass or right flank region, 15 cross 14 cross 14 approximate size, bimanually palpable, and it moves on respiration. So sonography suggested of grade 1 fatty liver, left kidney within normal parameters, right kidney, heterogeneous hypoechoic lesion arising from the mid and lower pole, displacing the cortex with some vascularity within. It measures 13.8 cross 12.5 centimeter. Prostate is around 18 cc. CT suggested a right renal lesion with interspread areas with fat density in mid and lower pole, involving pelvic-calyceal system, cortex, medulla, and up to renal pelvis, measuring around 13.7 cross 12.5 cross 14.2 centimeter. No any thrombus in renal vein or IVC. 2 arteries are noted. Query angiomyolipoma with secondary hemorrhage.
Okay. I
Can
think,
we see image?
yeah, Rathor, Aditya, you can just describe it. You can read the CT. Dr. Rathor?
Yes, sir.
Yeah, Aditya, you can go ahead.
So in the given CT images, we can see a heterogeneously enhancing lesion arising from the lower pole of the right kidney. The left kidney and the other non-urological organs seem to be normal. The mass is approximately 9 by 8 centimeter size, and it is near to the hilum. And majority of it is both 50% exophytic and endophytic. Vessels in this image, we can see two.
Yeah.
Go ahead.
Go ahead.
Two renal arteries on the right side.
IVC also seems thrombosed. Otherwise, the enhancement is there in IVC also.
How are you sure that vein is thrombosed? In these two images, it is just impossible to see the.
Yeah, sir. But
there's a nothing is called look like in the exam until you are sure.
Ask for more images, no?
Yeah, sir.
If you're doubtful, always ask for more images. Don't claim your diagnosis.
Okay, sir.
Otherwise, your Viva will go towards the how to recognize the thrombus in the renal vein and IVC, away from your main topic.
Any more images?
Brijesh, do you have more images?
This must be a video, no?
I think video file is attached with the PPT.
What about the?
It's attached, but somehow it's not playing. I will.
What about the HU values? Units.
Head component will have a HU of -10.
Okay, and CT reporting was AML. So what are the classical findings of features of AML and CT scan?
Sir, AML will have a fat density. It has a fat component also, and then muscle component and vasculogenic component also. So classically, fat component will be having a low HU, around -10 to 0, sir. And it should be AML, classical AML have no calcification.
What do you want to do? CT is playing.
What do you want to see? What do you want to see also in patient with the AML?
Sir, if there any hemorrhage or not, spontaneous hemorrhage.
Okay. Anything else? There are some renal tumors.
Associated syndromic features.
Exactly. Yeah. Good. Tell me which one.
Tuberous sclerosis, sir.
Tuberous sclerosis.
What are the features?
There is a sir Ashleaf macule chagrin patch, then facial angiofibromas, then cortical tubers,
Epidermal cyst,
epidermal cyst.
Okay.
adenoma sebaceum.
Yes, yes.
Yes.
So if I ask you the CT scan, can you see it is like a AML, and how you can say that this was an AML which bled? Can we replay the CT scan? Replay.
Brijesh,
Because hemorrhage has distorted the classical look of AML, but I observed in some plane it can be visible that it is a AML. The video axial wala ha. Just before the hemorrhage starts, there is a classical fat density is there within the mass. This is just to highlight for the residents.
yeah, Brijesh, is it not playing?
Yes, sir.
Play the video.
Yeah.
डबल क्लिक करके देखो भाई.
The file is attached, na? You open the file.
Okay, anyway.
Yeah, now you can do it. On the iPhone, you can enlarge it.
See that this one, the fat density is there in the mass. Now it's a hemorrhage. Okay.
Yes.
So this is where you can the CT scan you can differentiate that you can say confidently that it was a not heterogeneous mass, the tumor blood actually. Okay.
Yes.
So now in AML, what are the risk features, risk factors that predispose them to a spontaneous bleed, and what is called?
Usually, pregnancy is one condition, sir, where it leads to increased chances of bleeding, and we usually call it as Wanderlid syndrome.
What else? Other features, high risk features for spontaneous bleeding, because he
Then
is male,
size.
he cannot become pregnant.
Yes. Size of the tumor, sir. If the size is more than 4 centimeter, and as the size increases, chances of bleeding is more. Sir.
Okay. Next, other.
And
there are four. I think there are four criteria is in new books. 4 or 5. Like patient which is not compliant, size more than 4 centimeter, pregnancy, hypertension, and one more aneurysm.
Aneurysm.
At least AML is a very small topic, so you should read carefully and remember it. Okay. So what are the treatment options? How this patient was treated?
In this patient, angioembolization should be.
Okay. Why not upfront surgery? Usually, this tumor has a very good plane with the kidney, parenchyma, or surrounding tissue.
Yes, sir. Sir, first we have to check the vitals of this
I
patient.
want to know why in this case embolization was done. You should
know. Because it is a large tumor. So after doing angioembolization, it will shrink in the size.
In this case, it will shrink the size. Again, think carefully. why in this patient angio ablation was done. This patient has a spontaneous bleed. Okay, just to stabilize the patient and control the bleeding, it was done. Because if you operate in the emergency setting in this, there will be a good number of huge amount of bleeding.
Yes, sir.
Okay, that's why the patient was angioembolized. Now, if you operate this patient, then maybe you will find very less bleeding with a good plane.
So what treatment you want to give? You want to give him partial nephrectomy or you want to do radical nephrectomy?
एक बार स्कैन देख लो फिर से.
Brijesh, play it once. Aditya, Dr. Rathore, you see properly?
Sir,
What you want to do?
sir, I want to do the radical nephrectomy in this case, because mass size is too large in this case, encasing the whole kidney, sir. So I
They
don't
are
think
the
so.
benign tumor. They are a benign tumor.
But
Why you
partially,
want to a radical?
So we have done an angioembolization at this time. So we'll expect the mass to reduce, sir. So we'll assess
Yeah.
once, and if feasible, go for a partial nephrectomy.
There are some other features. There are some other features on the CT scan based on which we can decide about the radical nephrectomy, not the partial one.
Just see, play again. What you're going to see is the surrounding structure. What you're going to see is the vascularity and nearness to the vascular.
No. Gaurang sir also gave you hint.
This tumor is very close to the vascular hilum.
Yeah, if you see the medial part of the mass is very close to the renal vessels, whether vein or the artery, it is not clear. Okay. Any role of neoadjuvant therapy to reduce or shrink the mass other than angioembolization?
But in cases of tuberous sclerosis, we can give immunotherapy. Okay? That helps us to reduce the mass. If we have
Which immunotherapy? Which immunotherapy?
Sunitinib is
Everolimus.
Everolimus, sorry. Everolimus, mTOR inhibitors can be given.
mTOR inhibitor, not immunotherapy.
Yes. Everolimus.
What are the problems with therapy?
Yeah.
We can get
yes. Hypertension, proteinuria, not easy to tolerate. And this is not going to shrink any significantly. And it will take a long time. So a primary surgical option is a better thing.
Okay. So you did a nephrectomy or partial nephrectomy, and the HPR came as epithelioid angiomyolipoma. How will you follow up? So the follow-up of angiomyolipoma and follow-up epithelioid angiomyolipoma. There are also varieties called atypical angiomyolipoma. Anyone?
Aditya, you know the answer. Paras, if you know the answer, you can give answer. Mahendra, you only answer.
Yeah. So if we do a radical in this patient and it's a epithelioid AML is a slightly aggressive variety of AML, it needs more strict follow-up with CT scan and and chest X-ray or CT chest every 3 monthly for 1 or 2 years. Atypical angiolipoma and AML, the low grade, can be 6 monthly follow-up. But if you do a partial nephrectomy in these cases, again the chance of recurrence are high. Then again they need little bit in between follow-up, like 4 months or 6 months, based on the time and disease progression or disease recurrence. If no recurrence, then can we follow up annually after 2 years. So be aware of epithelioid AML in the pathology report. This is the aggressive one variety. So don't take it as a low risk and follow up after 6 months or 1 year. It also tend to metastasis also, a tendency for that. So be careful of this word.
Okay.
Yeah. Kashyap sir, anything to be asked in this AML?
No. So you were asking about, is there a feasibility for partial or a radical? You were asking. So for that they
Yeah.
have to examine more films and different sections,
Yeah.
sagittal or coronal. Look at the
Yeah.
vascularity also, the vessels, vascular anatomy, and then take a call.
Correct. And then we have to see from where it is bleeding. Which way? If it is a very peripheral vein, then it's okay. Correct?
Sir, actually, it is very difficult to see the
You don't
AML
get a
which point is
chance to
bleeding.
find where it is bleeding. You need to take a
Yeah.
decision early.
Yeah.
What was done?
Ganesh bhai, what was that?
Partial.
Partial. Huh?
ये बहुत छोटा दिख रहा है.
बड़ा कर लेते हैं ना.
नहीं वो ऐसा क्यों है, मतलब that window should become big, no?
हाँ. नहीं, yeah.
So sir, planes were good with the kidney parenchyma.
Planes were good. We could cut, and I don't know
I
if
can
there
see
is
the
more
renal
picture.
vein.
Half
I
the
can
kidney
see
was saved.
Yeah, this is a vein or renal pelvis?
नहीं वो
Renal vein,
mass ही
renal vein.
Is the mass.
नहीं
It's the
sir.
whole mass. 13 centimeter mass approximately.
No, the right one, which has the right where is the loop is there, vessel tape is there. That is renal
Correct,
vein.
correct.
No, it is not going around anything. It is just a loop there.
It is just lying around.
This was done how many? 1 month back?
Pardon, sir?
When was this done?
अभी 20 दिन पहले.
हाँ, because the 25 की जगह पे 26 लिखा है.
उसे 1 साल बाद लिखा है. अभी ये किसने स्लाइड बनाया? हमारे ब्रिजेश नहीं बनाया रहेगा.
No, sir. Patient was time traveler. वो 1 साल पहले आ गया खर्चा कम करने के लिए.
That's beautiful. No, the important
Nicely
thing
done.
is that, see, I think important thing is that we have got you have given a message that in such a big mass where everyone will think as a student that only the nephrectomy is an answer. Okay, but in this you have shown that partial can be done.
तो ये सेकंड पिक्चर जो है राइट साइड का, उसमें द मास इज कट. The fat
Yeah.
seen, this was the sinus fat actually for the upper kidney.
Yes.
मतलब we could distinctly see
Yeah.
it separate than the AML fat.
Correct.
And that's it. बाकी कुछ नहीं. And we could easily suture this off completely. In the inner rhinophary, which was individual, and outer one was like we do in robotic with barb suture. And there was a lip which was lateral, which was sutured on the medial margin.
Okay.
I don't think we have the final picture here, but that's all right.
Yeah, but it gives a good, understanding
The
that
key
how it will appear.
is to get the vascular control first.
Yeah.
So we got mobilization good. We got both the arteries. We got the vascular control. And actually the patient had bled. So
Before surgery?
Before surgery. So
Okay.
he had an episode of hypotension and everything 2 days prior to his presentation. Then we thought we'll do a angioembolization. Otherwise, the thought was also that we can take on table and go ahead with it.
Do it.
But with angioembolization, there was probably less bleeding, but not much shrinkage, like Kashyapi sir said.
When we do the angioembolization, within when we're planning surgery, we should
It's
be
not a routine protocol to do angioembolization. All AMLs, you don't do angioembolization. You can directly operate them.
when you're planning to do partial, then only like in cases if you have a borderline, patient can go for the radical or
This
partial.
patient had bled, and what Mahendra showed you inside the CT, there was an intra AML bleed. Those aneurysms which you saw.
Okay,
So these kind
So
of
the
patients can
answer is,
bleed more.
yeah, so the answer is normally we don't do it embolization. But in this case, it was done because patient was bleeding and they wanted that bleed should stop till the operation is taken.
Okay, sir.
What was the time period between angioembolization and surgery?
2 days.
3 to 4 days. So potentially like
Angioembolization
tumor
helps in
lysis
stabilizing
syndromes.
the patient.
Yeah, otherwise nothing.
Otherwise, they would have needed to go in early, emergency.
Correct.
Yeah, absolutely.
And you are lucky that it has bled inside the tumor. If it would have
It
bled
had slightly
outside,
bled outside the tumor also.
yeah. But if it was, like half a liter, 1 liter outside, then it is an
Not that
emergency
much
and
or whatever. It had.
yeah.
If you see that original CT, there's a small trickle on the renal vein and the IVC, which is seen actually. Which is not in that video. It was seen, but that's okay. Like it came out.
Good. Fine. Any other question you want to ask?
I think we are okay.
So IHCs include Desmin, I think, and something like HMB45. And there is a small distinction between RCC sometimes and fat poor AMLs on imaging. Fat poor AMLs and RCC.
Okay.
So sometimes you will operate an RCC and suddenly it will turn out to be AML. So that is fat poor AML.
Oh, okay.
Okay. I think let's stop here today.
Yeah.
Quite late.
Yeah, okay. Thanks
Okay,
thanks
thank
to all
you.
of you. Kashyapi,
Thank you, everyone.
Kashyapi,
Good
please
cases.
join.
Thank you.
Kashyapi, I will send
Yes,
you the
yes,
message.
yes,
Please
sir.
join. As okay.
Yes, sir. Yes, sir.
Thank
Thank
you.
you.
Good
Thank you.
night.
Good
Good
night.
night.
everyone.
Bye.
Good night.
Good night, everyone.